All right, let's go through some case studies for acid-base and electrolyte imbalances. So, a patient is admitted to the acute care unit. The patient has had severe diarrhea for 7 days and is currently presenting with hyperventilation and lethargy. The labs are taken and have been sent for analysis, and here are the lab values that come back. So, the pH is 7.2. The CO2 is 38 milligrams of mercury, millimeters of mercury, sorry. The bicarbonate is 15 milliequivalents per liter. The oxygen is 90 millimeters of mercury. And the oxygen saturation is 95%. And also of note, the patient has a low urine pH. So kidneys, that's tipping us off on the kidneys. So the reference ranges are pH 7.35 to 7.45, CO2 35 to 45 millimeters of mercury, bicarbonate 22 to 26. I think we're starting to see some things here. Oxygen 80 to 100, and oxygen saturation 95 to 100%. And so which of the values are outside the reference range? So obviously the pH is low, so it's acidosis. The CO2 is normal. The bicarbonate is low. So if pH is down and bicarbonate is down, metabolic, starting to tip us off. Oxygen is normal and oxygen saturation is normal. So those are our two abnormal values. The pH is low and the bicarbonate is low. And so we're going to look at, remember our acronym for remembering. So the likely diagnosis for this patient based on the lab values is metabolic acidosis. So we're going to say, is the pH normal? No, it's acidotic. It's low, indicating acidosis. Is the CO2 normal? Yes, it is normal. Is the HCO3 bicarbonate normal? No, it is low. So remember, respiratory opposite, metabolic equal. So pH low, bicarbonate low, that's the metabolic component. If both of those are low, the patient has metabolic acidosis. So we're matching the CO2 and the bicarbonate with the pH, and since both pH and bicarbonate are decreased, we know the condition is metabolic, and that makes sense for the patient's presentation. So metabolic acidosis can be caused by overproduction or inadequate excretion of hydrogen ions through or through excessive excretion of bicarbonate ions. So the kidneys are involved. There's something going on. Either the kidneys are involved because they're trying to compensate, or they are involved because they are you have kidney disease of some sort. So the metabolic causes for the condition can include impaired kidney function or just the severe diarrhea can be its own cause. Tachypnea, which is accelerated breathing, is often observed as the body tries to regulate the acid-base balance. So it's trying to blow off CO2 because you don't have enough bicarbonate to deal with it, and so you're in acidosis. Other signs may include confusion or lethargy, which we did see in this patient. So hopefully that one makes sense. So remember, if respiratory is opposite, so if you're acidotic and your CO2 is up, so pH down, CO2 up, you're in respiratory acidosis. If pH is down and bicarbonate is down, then you're in metabolic acidosis. And it's the same for alkalosis. So it would be if pH is up and CO2 is down, it's respiratory alkalosis. And if pH is up and bicarbonate is up, that's metabolic alkalosis. Okay. So we're in this case, we don't know about the kidney function based on the very short nature of this case study, but we do know that they've had severe diarrhea, and so they're losing bicarbonate ions and fluids in the diarrhea. They're also losing, the reason their urine pH was low is because they're losing the kidneys are trying to get rid of hydrogen ions. The fast breathing is trying to get rid of hydrogen ions because we don't have enough bicarbonate to balance them out because we've been losing it through the process of diarrhea. So that's why we have the low urine pH and the fast breathing, the tachypnea. So for electrolytes, patient is admitted to the hospital with acute onset dizziness and fatigue. So woke up this morning, they were dizzy and fatigued. Upon the chart review, you notice the lab values in the electrolyte panel. So the reference ranges are in parentheses, and a lot of times when you're in the hospital, that's how you see it. You see the labs, and it'll have the reference values in the parentheses, the reference ranges, and then a lot of times it'll have some kind of notation if it's high or low outside of the range. So it's really easy to spot. So sodium is 140, and that's within that range of 134 to 142. Potassium is 6.0, and that is high. Potassium's high, so we're talking hyperkalemia now. Calcium is within the range, chloride is within the range, phosphate is within the range, and magnesium is within the range. So potassium is our value that's out of the reference range. So based on what we know about hyper and hypokalemia, which of the following clinical presentations would be most likely in this patient? And are they going to be appropriate for therapy? So what we know about hypo and hyperkalemia is they can both cause cardiac arrhythmias. So cardiac arrhythmia is going to be the most likely clinical presentation of this patient, and they are not going to be appropriate for therapy. Confusion, headache, and seizure might be due to something else. So arrhythmia is the most likely clinical presentation. So all the values are in the reference range except the potassium, which is significantly elevated. So the most likely clinical presentation for high potassium hyperkalemia is arrhythmia, especially when the potassium is greater than 5.5. So potential clinical presentations for high potassium include muscle weakness and or paralysis, another reason why they wouldn't be appropriate for therapy. Paresthesias, which is that pins and needles feeling in your hands and feet. Bradycardia, slow heart rate. Heart block, where you're not getting the conduction going right. Ventricular fibrillation, which is about the most dangerous arrhythmia. It can kill you. And cardiac arrest because of the ventricular fibrillation, likely. So hyperkalemia, to that degree, is a very dangerous situation, and the person is definitely inappropriate for therapy at this point.